Mastering NeoDent Implants, Surgical and Restorative Protocols Explained. I want to start by thanking our sponsors, Colteen, Oral Arts Dental Laboratories, and Romero Dental Seminars for making this webinar series possible. I also want to direct all of our viewers today to our YouTube channel, Romero Dental Seminars, and I want to ask you to please click on the bell so that you can get instant notifications of any updates and subscribe to our channel. Thank you for your continued support. I also want to announce our 2025 live seminar series is starting in September, Friday 19th, September 19th, and Saturday, September 20th. We're going to have our Mastering Porcelain Veneers, a complete hands-on seminar from preparation to cementation, held in beautiful Sarasota, Florida. Do not miss this opportunity, since this seminar is only given once every 2 years. So we hope to see you in Sarasota, Florida, September 19th or 20th. And to register, visit our webpage, romerodentalseminars.com. Our objectives for today's presentation is understand the drilling sequence for NeoDent implants and highlight the clinical steps for implant restoration. So let's get started. So to understand the drilling sequence for a NeoDent implant, I'm going to literally share with you a case where I'm going to be placing a 3.5 millimeter implant. Now I'm sharing with you this chart here because this chart will guide you through the process of placing any NeoDent diameter implant. But we're going to focus on the 3.5 millimeter diameter implant because that's the one that I will be placing today with you while I'm explaining the sequence of drills. Now, this sequence will be the same for any other diameter. All you need to know, of course, is that you're going to use wider drills until you get to the diameter that you are trying to place. But for now, let's concentrate on the beginning of the chart, where we have the initial drill, the 2.0, the 3.5, and the 3.5 plus. All these 4 drills I will be using in the case that I'll be sharing with you, and I'm going to tell you why I go through all of these. And in my case, in this case that I'm sharing with you, none of them were optional. I just decided to use them, and I'm going to tell you exactly why I decided to use each and every one of them. So let's get started with my case. So I have this patient that I had fractured this second premolar. Initially, I was planning to remove the fractured tooth and place an immediate implant. But when I removed the remaining root that was there was a small sinus communication. So I decided to graft the area let me go back one. I decided to graft the area before I went ahead and placed the implant. And I allowed the patient to heal for 4 to 6 months before I went ahead and now did a surgery during a second clinical event. So during the first appointment, we extracted the root, we grafted the area, we sent the patient home. She came back 4 months later, looked at everything. We were happy with what we had, and we waited maybe a month or a month and a half more, and then we decided that we were going to place the implant. So now she's ready for the implant, and we're going to start our implant osteotomy preparation. So for when I do these cases, in this particular case, we're going to do it free-handed. NeoDent Implant also offers the Easy Guide system, which is a fully guided system, a protocol that you can also use. I've used it myself. Very, very intuitive, very easy also to use. But in my practice, when I do a lot of these single implants, I definitely I do them, the majority of them, I'm going to do them free-handed. And the first thing that I want to share with you is I always use this initial drill, which is a very sharp drill. I mean, if you look at the tip of this drill right here, it's very, very sharp. It's very pointy. And what I like about it is that when I literally just go through the tissue without rotating the drill, I just pinch through the tissue until I touch the bone. And I'm looking at, I call this the bleeding point technique. I'm looking at where that bleeding point is located. And I'm going to say, okay, this is very close to where I want the implant. This is centered. So once I'm there, I'm going to now go ahead and go back through the tissue, touch the bone, and then start hitting the rheostat so that the drill rotates. And I'm going to go approximately at 800 RPM, and I'm going to go in, and I'm approximately going to go in 5 to 7 millimeters deep into the bone. Now, the implant that I'm going to be placing is a 3.5 times 10 millimeter length implant. So I know that 5 millimeters is only half the length of the implant that I'm going to be placing. But the reason why I only do 5 millimeters is, again, because if I made any mistake, if I'm slightly off, and I think I am slightly off when I look at that photo right here, I know that I can make any correction still, because this is a very narrow drill, and because I've only gone, half of the depth that I have to go. So that's how I always do it. So I go in, I go through the tissue, I hit the rheostat, go 5 millimeters in approximately, remove the drill, and then this is what I see. So I see a little bit of a bleeding point. Now I'm going to go to my second step, and my second step is, now let me flap the tissue. Now I know that there's a lot of dentists out there that like and promote, flapless surgeries, and I don't have anything against that. I think it's a great way of doing things. I just don't like doing them. I like flapping. I like looking at the bone. I like looking at the thickness of the tissue. I want to make sure that my implant is located 1.5 to 2 millimeters, specifically for my NeoDent implants, 1.5 to 2 millimeters below the crest of the bone. This is what the protocol requires. So I want to make sure that I look at all these little things, and I want to make sure that I'm also dead centered between both of the teeth. So what I'm going to do now is that once I elevate that flap, now I have a direct view of that little dimple that I've created into the bone with this initial drill. So right on top of that dimple that I've created with that initial drill, I'm going to use my 2.0 drill. Now, if you look at the 2.0 drill, which is right here on the right hand side, you can see that this drill now is a little bit wider on the tip. So if I were to use this drill from the beginning, this drill will just bounce off the bone, and it will be really hard for me to set a straight path through that, or straight path and direction to where exactly I want my implant to be located. That's why I always use that initial drill, because that thin tip that the initial drill has literally stabilizes itself on the area where I want it, that area, exactly the area where I want to place my implant. So now I'm going to use this 2.0 drill, and this one is going to literally sit on that dimple that I created with the previous drill, and now I'm going to go into full depth. So now that I know that I'm at the right direction, that I'm dead center, I'm going to go in, and I'm going to go in not 10 millimeters, but I'm going to go 12 millimeters, because the implant that I'm going to be placing is a 10 millimeter length implant, and I want to make sure that this implant is 1.5 to 2 millimeters below the crest of the bone. So that's going to give me not only a full coverage of the implant with bone, which is what we all want. Don't forget that has this implant has a 3 millimeter platform switch connection. So that platform switch is going to allow the bone to grow around that area of the implant that is 1/2 of a millimeter, 0.75 millimeter away from the connection, the actual connection of the restorative component. So that's going to allow some of that bone to grow in that area, and at the same time, I'm going to have enough tissue thickness. And if I don't have enough tissue thickness, I will do what I called what has been called a tent pole technique, which is just placing a healing abutment, a short healing abutment that I can cover with the tissue, so that I can allow some of the tissue to regenerate on top of that healing abutment. That's not the topic that we're talking about today. I just want to emphasize that this implant requires you to be 1.5 to 2 millimeters below the crest of the bone. So now I'm at a 12 millimeter depth preparation. With that 2 millimeter drill, I'm able now to use this paralleling pin. Now the paralleling pin is a 3.5 paralleling pin, so it's the same diameter as the implant that I'm going to be placing. And as you can see here on the x-ray, this paralleling pin is not all the way down, because this implant is conical. So the tip of the implant is going to be a little bit narrower. So you can see that the actual paralleling pin is more parallel. So this is going down maybe 10 millimeters. So it still has to go down 2 more millimeters, and you can see it right there on the x-ray. But what this is telling me is, it's kind of, am I in the right direction? I'm answering just a lot of the questions that as a restorative dentist you should have. Am I centered? Am I at the right location? Is my prosthetic component going to be located where I want it to be? Am I going to have enough tissue surrounding this crown so that I have papilla, mesial, and distal of this implant? All those questions that we know that we're asking ourselves as a restorative dentist, I'm viewing right now when I'm at the same time that I'm looking at this pin, and I'm saying, okay, I'm dead center. I know that I have enough tissue thickness. The only thing that I didn't that I knew that I needed is because the bone was very, very dense, and I can feel that when I was prepping that osteotomy. So I knew that I was going to have some type of difficulty inserting the implant. So what do you do there? What does the NeoDent protocol require you to do when you feel that you have more dense bone, and for that 3.5 or that 4.0 implant, or whichever diameter implant that you're going to be placing? Well, they have these drills called the plus drills, and that's the drill that you're seeing here on the right hand side. This plus drill, what it means to what's meant to do is, again, to add a little bit more size to the osteotomy. So it's going to be closer to the diameter of the actual implant instead of being at the 3.5, because the 3.5 drill is not really 3.5 millimeters in diameter. It's probably 1.5 millimeters less than the actual diameter of the implant. With the plus drill, you're going to get closer to the size of the implant, and that's going to give you less friction. It's going to allow that implant to be inserted with, you're still going to have a lot of primary stability. Believe me, when I placed this implant, the primary stability was amazing, but you're not really trying to force the implant inside the osteotomy. And in a way that I had found over the years to kind of identify that, because sometimes I have that issue that I'm trying to place the implant, and I notice that the implant is halfway through, and my motor, which is now at 35 to 40 newton square centimeters of torque, has stopped. So I know that I'm at 35 to 40 newton square centimeters, and that implant is not even halfway in. So I know that I have too much resistance from that bone. What I would do is I would retrieve that implant and I would use that plus drill. So the more you do this, the more you will have the feeling in your hands, and the more you would know when is that plus drill needed. Now, you don't want to use a plus drill on a bone that is not giving you any resistance, because you don't want that implant to be loose. But that's one of the things that I like about the NeoDent system, is that honestly, the primary stability that you gain with this implant is really amazing. I mean, I've yet to have a case where I have one of these implants that is spinning, or that I don't have enough torque, if the protocol of the surgical procedure, of course, is followed to the T. We can always make mistakes, and if that's the case, you can always correct it by using a wider diameter implant if it's possible, or you can place an implant and just bury the implant there and just leave it there for a little bit longer time if you feel that the torque was not there at the day of insertion. But in this particular case, we use a plus drill, and after using that plus drill, we're going to use this 2.8, 3.5 drill that you're seeing right here on the right hand side. And what this drill is for is just to create a little bit of opening on the coronal aspect of your implant. Don't forget, these implants are conical in shape, so they're a little bit wider toward the restorative side. So again, in order for you to create that nice anatomy of your osteotomy, I just go in and you only have to go in with this drill a couple of millimeters. You don't go all the way down. It's just to kind of flare that occlusal aspect of your implant a little bit more, to allow that the shape of the implant to confine better to the shape of the osteotomy that you have created. And once you do that, then you're ready. Literally, there's the 3.5 drill that I've already created that extra uh, opening on the coronal aspect of the implant. And once you do that, now you're ready to insert the implant. And what I like about the insertion tool of the NeoDent system is that it has these three little lines which represent each 1 millimeter. So now you know that if you place the implant and you don't see one line, you know that you're a millimeter below the crest of the bone. So it gives you a good reference, so you know exactly where you are. And as you can see right here, this implant is completely submerged within that bone. This is a grafted site, but this was an extraction in a graft before we placed the implant. So again, the stability was really, really good. You can see that the implant is dead center. That prosthetic component of the implant is exactly where I want it to be. I know that I'm going to be able to provide this patient a really good restorative or restoration after this implant it heals and it's ready for me to restore. And once I do that, I like these peak healing abutments that NeoDent has for their implants, and I know that there's other companies out there that also make them today. And what I like about these peak temporary abutments or healing abutments is that you can actually put some composite on them if you wanted to customize them and to create a specific type of shape of your emergence profile. So I normally do that. I can sometimes I modify them with flowable composite. In this particular case, I chose to use a very wide one, which was more than enough for me, I thought, at least for that initial phase. And all I do is just screw it into place and then place my sutures And yes, you can see that there's a little bit of tissue covering my peak abutment. I could have chosen a taller one if I wanted to, but I decided just to leave this one because I know that the tissue is going to retract a little bit once it starts healing, and that's exactly what happened. This is the day of the suture removal. You can see that the tissue is not growing on top of the of this temporary abutment. I have the temporary abutment at the level of the gingival margin, which is great because that way my patient can just continue her life, eat whatever she wants. We're not going to have any micro movement of the implant. Not that I'm afraid of. I think that the only reason why I didn't immediately load this implant was because of the grafted site. I just wanted to be more conservative. It didn't bother the patient to be missing a tooth there from an aesthetic standpoint. So we just decided to leave that there and allow this implant to heal for 3 months and then go back and restore. But what I do like about these peak abutments is that well, this is just a sequence of events. I just wanted to share with you. This is the right before where the tooth fractured. I removed that root, and you can see that we had a little bit of a communication. The root was right on the floor of the sinus, so when we extracted the root, there was a little perforation here. So I decided that's the reason why I decided to just graft the site, allow that to heal for 4 to 6 months, and then bring back the patient, and then start placing the implant. This is the final X-ray of the implant placed in that healed socket preservation site. And you can see that this implant is 2 to 2 millimeters below the crest of the bone. I have that peak abutment that you can't see on the X-ray, but it's already placed. But what I want to show you is that this is a different case where I use this is a 7 millimeter diameter. I think it's a by 5 millimeter in height of an implant, and I did this because you can see where the sinus was, and I did a sinus bump when I was placing this implant. You can see it right there, but this implant was also placed a couple of millimeters below the crest of the bone. There is the um, that peak abutment, peak healing abutment. But when I removed the peak healing abutment, we waited 5 months for this case in order for us to restore. You can see that tissue, the maturity of the tissue, beautifully mature tissue around that peak abutment. And that's one of the things that I love about it. It really allows for good healing. And you can see the band of tissue that I was able to create around this implant in order for me to restore this case in a really good way. I did end up pushing the tissue a little bit further out by adding some composite to the same peak abutment before we went ahead and took impressions. But this is just a surgical part of it, and how I do it, and why again I recommend these NeoDent implants, because I really think that they're very easy to use, very easy to restore again. And as general dentists that we do multiple different procedures, I personally like to try to use things related to implant dentistry that maintain my dentistry or my workflows every day, just simplified. Because if they're simple and you make a mistake or something happens, it's easy for you to kind of navigate, okay, what do I need to do to correct this? Now, my second objective for today was to highlight the clinical steps for implant restorations. And again, this has become so easy today in the world of digital dentistry. This is a very nice case that I recently completed. This patient was going to lose teeth 7 and 10 due to periodontal disease, due to a periodontal issue on those two teeth. So I actually scanned him before. I scanned his upper and lower jaws and bite before they extracted these teeth. They were going to extract 7 and 10, and they were also going to extract tooth number 13, if I'm not mistaken. So, and all three were going to be replaced with implants. And again, this is now after the extractions were done. The implants were already placed, and you can see here that I have already added some flowable composite on the healing abutments. These are now metal healing abutments that we're using for this case, but I've added some flowable composite there just to kind of push the tissue away, just to kind of customize these healing abutments, and I leave them there, until I'm ready to restore the case. Now, the other benefit that I have for this case is that I had a pre-operative scan of the way that 7 and 10 and 13 were in his mouth. So when I was ready to restore this case, I took some photos, I selected the shade, but I shared the pre-scan of this patient with the lab so that we were going to try to maintain the same shape and form that he had, with the minor improvements that he had in his teeth prior to the extractions. So again, I always do a scan of my custom healing abutments, and you can see I'm sorry, it was number 12 instead of 13, and 7, 10, and 12. And you can see that I'm scanning just the healing abutments, just to kind of give the lab, okay, what that emergence profile should look like, what is the support that I'm giving them there. You can also then give them a scan without the custom healing abutments, but before you place your scan bodies. But again, in this particular case, I just did the healing abutments, and then I removed the healing abutments. I scanned the scan bodies, and you can see that now here is all the data, scan body, all the data is just connected together, merged. All the measures are merged together here, my scan bodies, the healing abutments. And then as I said, I also send them the pre-op abutments. And now these are the crowns, because what else is it to this? Nothing more. If you have all the data, if you have all the information, and you select your shade and you send all this information to the lab, all the lab has to do is get you back your restorations. And as you can see here, look at the tissue around these implant crowns, and they look just, and the crowns themselves, they look just like the natural teeth that the patient had before we extracted them. And this was all done again through that pre-op scan and through a good selection of shade. These are 3 screw retained crowns, and those are the only type of crowns that I do in my office, screw retained, because they're retrievable. Because if something were to happen tomorrow, I can unscrew them and I can go back to square one. I don't have to cut a crown off. I don't have to do anything like that. So I don't like cementing crowns. All of them are screw retained, either through a custom, either they're cemented in the lab on a custom abutment, or they're just one component with the UCLA type of abutment, one component that goes directly into the implant platform. So one or the other, whichever you decide. But this is what we did for this patient, and this is a really good example, of the ease that we have today with all this technology on how we can try to reproduce nature as close as possible for cases like the case that I'm sharing with you from this gentleman. This is now his full smile, and you can see how the teeth have blended in very nicely in this new smile. And if you look at the preoperative photo and you look at the completed case, you can see that they're very, very similar. Because again, what did we use in order for us to try to duplicate them? We use the preoperative scan, so that allow us to get very minimal adjustment in relation to the occlusion. But most importantly, it really gave the patient that satisfaction that his teeth weren't perfect. We didn't give him perfect teeth. He wasn't looking for perfect teeth. He was looking for something natural that just blended in, and because he didn't want to do more dentistry than what he really needed. And that's really what dentistry today is all about. Dentistry today is about replacing what's missing, and not having to you do multiple restorations on patients' teeth just to make everything look like a Hollywood or a perfect smile. And that, at least that's what I think, and that's what I believe in, and that's what I try to provide my patients. So this is my last slide. I want to thank you for watching this video. And again, please don't forget to share our YouTube channel with colleagues and friends, because that's really going to help support our efforts in what we try to do through our YouTube channel. Thank you again for watching, and see you during our next webinar.